This congenital defect video is meant to be watched only when studying for pediatrics. That is, there's a surgical topic which includes all of the congenital defects that you should not watch if you're preparing for the shelf, but you should watch when preparing for STEP. Things like tracheoesophageal fistula, esophageal atresia, imperforate anus, and some of the biliary emesis diseases are discussed elsewhere in pediatrics. This is just going to round off knowing all the diseases. So these are going to be surgical diseases that we haven't talked about somewhere else. We just have to get through them one at a time. The first is diaphragmatic hernia. And a diaphragmatic hernia is a congenital hernia, essentially a hole in the diaphragm. And that hole in the diaphragm allows bowel to get up into the chest. Now that's not such a big deal except for the fact that because bowel is there, lung cannot expand, and therefore the lung becomes hypoplastic. And that's the big deal with this condition. Now the patient is going to present with a scaphoid abdomen. Most babies have protuberant bellies. Because there's a hole in the diaphragm and the bowel's up in the chest, it looks scaphoid. And there's bowel in the chest. Now you don't have to remember the eponyms for the different kinds, but I do want you to know that it occurs more often on the left than on the right, and more often in back than on the side. The diagnosis is going to be mostly clinical, but you want to confirm that indeed there is bowel in the chest by doing the x-ray. This is effectively the babygram. And the treatment is surgical repair. That makes sense. You want to fix that hole and bring the bowel back down. But again, the most important part of this disease is that the lung is hypoplastic. So you're going to give corticosteroids to help develop the lung. So the big thing to remember about diaphragmatic hernia is that, yes, it's a problem with the diaphragm and the bowel, but what you have to take care of is the lung. These next three, when you look at them in a patient, you will not confuse one for the other. But in a vignette where they're using words to describe what could be easily shown in a picture, it is very easy to confuse them. We're going to talk about the difference between gastroschisis, omphalocele, and exstrophy of the bladder. Here are the key words you need to look for each one. First, sound out gastroschisis. It sounds nasty and ugly. Use that as an advanced organizer, where omphalocele sounds like an elf or a dwarf. You'll see what I mean in just a minute. See, the gastroschisis and omphalocele have the same pathogenesis, almost. It's a problem with when the gut comes out of baby, twists, and then comes back in. What does that mean? Don't worry about it. This is not embryology. But what it matters is gastroschisis is ugly sounding and omphalocele is kind of pretty, well, at least compared to gastroschisis. So here you've got a baby, a plump, rotund baby, and here's midline. Same baby, nice and plump, rotund, midline. Gastroschisis is the defect of the bowel that's off to the side, to the right of midline, and is angry, nasty looking. Whereas omphalocele is going to be midline and not that ugly. That is contained. The difference between gastroschisis and omphalocele, because they're both bowel, is that gastroschisis is to the right and bowel's all over the place without a membrane, much worse than omphalocele, which is midline and has a sac around the bowel. Both conditions are clinically diagnosed, and both are treated with a silo. As you literally put a sterile towel around them and then basically twist the bowel over time back into baby. Gastroschisis to the side, omphalocele midline. Now, if you had only that, you might also confuse exstrophy of the bladder for omphalocele. because exstrophy of the bladder is also going to be a midline defect. But they're going to give you other clues in the vignette, such as wet with urine, or shiny and red. And most importantly, there is no bowel. You look at the thing, and it's a sack of water. But you can see how if someone were describing midline lesion, a little red, no bowel, you might be able to confuse omphalocele and exstrophy. Exstrophy of the bladder is also a clinical diagnosis and requires surgical repair. Biliary atresia is one of those causes of pathologic jaundice. The patient is going to present with a worsening jaundice at about 2 weeks. And it will be direct hyperbilirubinemia. Biliary atresia, pathology is in its name, the biliary ducts never get made, so bile can't get from the liver to the duodenum. You begin the workup by looking with an ultrasound, and you will see no ducts. To confirm this, and this is what the tests like to ask, is you do a HIDA scan, but only after 5 to 7 days worth of phenobarbital. The phenobarb should stimulate the biliary tree to secrete bile. What you'll see is that the HIDA contrast never makes it to the duodenum. Having made the diagnosis, of course, you're going to resect the atretic segment and reconnect. Cleft lip and cleft palate is where we bring these guys up. A lot of things can go wrong with the formation of the mouth. Either there can be a failure to grow or a failure to fuse. And it might be of the soft palate, the hard palate, or the lip itself. And depending how bad it is, it may be quite superficial or all the way to the deep structures of the sinuses. And it can be bilateral, unilateral, or midline. The idea is that the growth plates have to fuse together as they grow into an arch. And the front of the mouth has to come together and then basically zip up. If you fail to zip up, you might have a hole in the middle. If the growth plates grow weird and then fuse weird, they might be off to the side and they might never come together. And this is primarily a cosmetic issue. It's a big deal because it's on their face, but there are some kids who have it really bad and they're not able to latch. So they're going to present with a failure to thrive. And this is a clinical diagnosis. Baby comes out and you can see that it's cleft. But it may be worse than you think it is by looking on the outside. And that might be indicative that there's a deep structure involved because the patient presents with recurrent infections. Still, you're not going to need very much imaging. You can just see it. And the idea here is you want to fix it surgically. The lip is usually done earlier, 11 to 12 weeks, while the palate is done later, 11 to 12 months, and in between you're going to use special devices to help the baby latch and actually feed. We're going to close with neural tube defects. We're going to close with it because it takes the longest because it's the hardest to understand conceptually, but it's actually one of the easier diseases. Neural tube defects, spina bifida spectrum, are caused by genetic disorders and folate deficiency. The thing is that the neural tube develops very early on, so if mom comes in not on folate and then you start her on folate as her pregnancy progresses, it's probably already too late. Mom should be on folate supplementation prior to getting pregnant. What happens is that the caudal spine fails to form. And the way you're going to know this is in one of two ways. Either there is prenatal care, and a quad screen shows an elevated AFP, and then an ultrasound prenatal is going to show the disease. That's how most people get captured in our country. Actually, most people get put on folate and it doesn't happen. But you might have someone who has no prenatal care, who just shows up to the emergency room, and then the baby is delivered. Well, it's hard to miss this unless it is on the lower end of the spectrum in severity. So you might just present with a little tuft of hair, or it could be a full-blown meningomyelocele. Drawing these becomes very difficult because you have to keep track of the spine, the skin, the CSF, and the nerves. So bear with me as we do this. The anterior spine is always going to be fully intact. And the posterior spine normally is fully intact. And in this space are going to be the nerve fibers running through. And also in this space is going to be CSF, identified in blue. And throughout all of this, of course, is the skin surrounding these internal structures, represented in green. Green skin, black bone, blue CSF, red nerves. Now, in the mild form of the disease, where the anterior spine is always normal, you're going to have a breakdown of the caudal spine, represented by the gaps. Anterior spine is normal. In this form of the disease, the nerves are still where they're supposed to be, as is the CSF. The skin on the front is normal, and the skin on the back might show a little tuft of hair. And the idea here is that rather than the spine, there is the skin that is essentially protecting the spinal cord. This is occulta. As the disease worsens, remember we're going to have the anterior be no problem. We lose the protection of the spinal cord and back. This is going to be true of the next two severe diseases. And then what defines this disease is how much comes out of the hole. The nerves in a meningocele are where they're supposed to be. But the CSF comes out in a little outpouching. The nerves are where they're supposed to be, but the outpouching has CSF in it. The skin in the front is normal. And out of baby's back is this sac. And the sac has no nerve fibers in it, but CSF. This is the case of meningocele. In the most severe form of the disease, you have that same sac, but also in the sac contain the nerves. CSF is still where it's supposed to be, but it's also got the sac that pops out back. Again, the skin in front is intact. And in the rear, you can see the defect. Both CSF and nerves are visible. This is the meningomyelocele. The diagnosis is going to be made either prenatally or on visual inspection. And the treatment is to repair it surgically. What you need to be aware of, though, is that anyone who has this disease is at risk for getting something else. First, there's an association with Arnold-Chiari malformation, hydrocephalus, which can lead to developmental delay. And lastly, a focal neurologic deficit below the level of the lesion, especially in the case of meningomyelocele, where the nerves may be compromised, so you can get sensory, motor, bowel, and bladder dysfunction. Okay, in this lecture, Congenital Defects, it's sort of a hodgepodge of the diseases that didn't fit in anywhere else. We talked about diaphragmatic hernia. Remember the hypoplastic lung, scaphoid abdomen gives steroids. Gastroschisis, nasty sounding, right side of midline, no cap, bowel everywhere, silo. Omphalocele, not so bad sounding, midline defect, surrounded with a sac, the better one to have, also a silo. Exstrophy of the bladder is thrown in there to also confuse you from omphalocele, but look for things like red and shiny or wet with urine or no bowel present. That's exstrophy. Surgically repair it. Biliary atresia is that direct hyperbilirubidemia. Ultrasound shows no ducts, get a HIDA scan. Cleft palate and cleft lip, what you care about is the failure to thrive and the recurrent infections. Fix it when you can. And lastly, neural tube defects, which is a folate deficiency, which you'll catch on a quad screen during prenatal care. Or you won't catch it on prenatal care for some reason, and what you're looking for is that meningomyelocele. That is Peds congenital defects.